you, Michael. Thank you, everyone. Good to have you back. It's just grand to be now on our second go round for year 2. Good to have such a joining us once again. Today, it is my great honor to present my colleague and friend, Dr. Michael Collins, who's a senior clinical investigator at NIH in their skeletal disorders and mineral homeostasis section. Michael is a physician scientist trained in endocrinology at the NIH, where he's been for the last 20+ years studying bone and mineral homeostasis. He does primarily translational and clinical involving patients with rare bone and mineral disorders. A major focus of that work has been the regulation of phosphate homeostasis by PTH and FGF23. And that's what he's going to talk to us about today. So Michael, it is just here. Thank you. Look forward to a great talk.
Thank you. Thank you, Laura. I appreciate the introduction and I appreciate the invitation. I did just want to quickly thank some of the people who are making this possible, especially the OI Foundation, Tracy Hart and Michael Stewart, who have done so much for this. The Rare Bone Disease Alliance and Charlene Waldman, who has done so much. The Bone Echo Project, Michael Lewicki has done so much, and the Fibrous Dysplasia Foundation, with which I'm closely affiliated, who is also one of the organizations involved in this. So today I have been given the topic of evaluation of patients with hyperphosphatemia. And I'll first show my disclosures, which are here. And then this is the approach to the talk that I'll take today. First, I'll give some background on phosphate, talk about the differential diagnosis of hyperphosphatemia, and then move into hyperphosphatemia more specifically as it relates to rare bone and mineral disorders. And by the end, the primary focus of this will be on the related rare bone and mineral disorders, hypoparathyroidism and tumoral calcinosis. So just to set the stage and make sure we're all arriving at the same place and give us a context, I first will get my screen frozen. So, all right, so things are a little sluggish. Okay, all right, so the first question, why phosphate? Well, you know, it's sort of a rhetorical question. Obviously, phosphate is super important in so many biological processes. And it's fortunate then that phosphate is so abundant in the environment that we don't usually have to worry too much about it. It is, of course, involved in the generation of ATP, and phosphate deficiency disorders can result in abnormalities there. It's, of course, involved in nucleic acids, DNA, RNA, the phosphate component of phospholipid membranes, and of course, cyclic AMP and phosphorylation as part of signaling. But for us and for this group, the reason we're interested about it is this, and this is hydroxyapatite. And you can see the composition and the structure of hydroxyapatite, which is primarily calcium and phosphorus. And so hydroxyapatite is the hard stuff. It forms a biological crystal that then coalesces to form, with collagen primarily, to form the hard stuff that makes up bones and teeth. So that's one of the main reasons why we in the Rare Bone Echo are interested in phosphate. What I will just add here while I have the opportunity is to show you that hydroxyapatite is not always the same structure. So depending on the tissue and depending on what you've been exposed to in the environment, there are important substitutions that can take place. So, for example, you can see how strontium can be substituted. Strontium, which is used for a treatment for osteoporosis. Bone is also a major reservoir for magnesium, so this is where magnesium is stored. Fluoride can get incorporated where the hydroxyl group gets into hydroxyapatite, and of course, there's problems related to too much fluoride, fluorosis. Anyway, so this is why we are interested in phosphate here today. So then you may ask, why are we interested in hyperphosphatemia? Well, hyperphosphatemia, the primary problem with it is that it's a risk factor for pathological calcification. So these can be vascular calcifications or soft tissue calcifications. And you can see here are coronary artery calcifications in stage renal disease, nephrocalcinosis, calcification of the kidney that can occur in hypoparathyroidism, basal ganglia calcification, which can occur in hypoparathyroidism as well as other disorders. And then there are a couple examples here are the calcification that occurs in patients with familial tumoral calcinosis, one of the disorders we'll talk about later. And this is calcification of the peripheral arteries, as are shown here in the top panel, and then ectopic calcification, soft tissue calcifications, as is shown here in the lower panel. So, an important consideration in regard to the risk of calcification that's often talked about and important to know about is the calcium phosphate product. So what is the calcium phosphate product? Well, it's simply the concentration of calcium times the concentration of phosphate using the same units, and that's called the calcium phosphate product. So then the question is, what is a harmful phosphate product? At which point do we get in trouble from a high calcium phosphate product? Well, there's some debate about this. It's somewhere between 55 and 140. Well, that's quite a range. Generally, I would say for most clinicians, we agree that 70 is pretty definitely the upper limit of normal. That 70 and above we begin to get concerned about, or we should be concerned about the risk for calcification that can take place. I'll let you know that in the renal field, which is a major, probably the most common disorder of hyperphosphatemia, that the recommendations from the KDQI organization is that the phosphate calcium product be kept below 55 milligrams per deciliter squared. So, well, how valid are these numbers? And again, there's debate about that. One question is the calcium phosphate product any better than simply the phosphate concentration at predicting the risk for calcification? And if we're talking about end-stage renal disease, the answer is probably no. And this panel that I have on the right, the lower right here, shows you a very nice study that was from quite a while ago. But you can see very clearly, this was a study where an intervention was brought about to lower the blood phosphate levels, and they looked at the effect on the calcium phosphate product, where you can see that the calcium phosphate product completely parallels the phosphate concentration. So in end-stage renal disease, maybe the calcium phosphate product per se is not so important. But in other disorders, some of which that we deal with, where there's changes in the blood calcium level at the same time with changes in the phosphate level, this can be a problem. So it is a useful determinant, the calcium phosphate product. It's not written in stone, but it is something I think that's important to know about and something important to follow in patients. Okay, so where is phosphate in the body? Well, you can see here, the vast majority of phosphate in the body is sequestered into bones and teeth, where it forms both mechanical function, as we saw in that it makes the hard tissue, bones and teeth, but also it serves as a reservoir from which calcium and phosphate can be drawn. The calcium phosphate product that we talk about, the blood phosphate concentration that we talk about, really derives from this small pool of extracellular phosphate. So this is what we measure in blood, and this is what we measure in urine, and this is what we pay attention to as clinicians. So where is the phosphate and how is it handled? How does it get from one place to the another? So this is a cartoon from Monroe Peacock's recent publication in Calcified Tissues International, which you'll see I have several cartoons from this excellent review article that I use. It's really a very good review if you want to get up to speed on this. So these are the places where phosphate is brought into the body, excreted from the body, and exchanged throughout the body. So you can see that in a Western diet, we consume a lot of phosphorus. In fact, the average consumption of phosphorus is about 1,400 milligrams a day, whereas the RDA is only 700 milligrams a day. So anyway, that phosphate is ingested, and most of it is absorbed from the gut. It goes into extracellular fluid. Some of it is exchanged in and out of the bone, and you can see that under normal circumstances, bone resorption, I'm not sure if you can see my pointer, I hope you can. Bone resorption is roughly matched with bone formation. Of course, this changes throughout life, and it changes as a result of certain disease states. Phosphate also exchanges in and out of muscle and soft tissue, where it's used for ATP and other biological functions. But probably the most important aspect of this, and the one we'll spend the most time on, is the kidney, because the kidney is really where the vast quantities, the majority of phosphate is filtered and reabsorbed, and it represents the place where the lion's share of phosphate regulation takes place. So we'll focus on that a little bit more later. But first of all, we'll talk about the gut, because this is an important determinant as well, and it is something that we can now begin to manipulate. Okay, so again, this is another cartoon from Professor Peacock's recent publication. And across the top, you see the enterocytes. Just below them, that would be the lumen of the gut. And you can see at the bottom, we have the various stages of the gut, the duodenum, the jejunum, and the ileum. And you can see the majority of phosphate is absorbed in the jejunum, and it's absorbed through several processes. So there's two broad processes. There's the transcellular process, by which the sodium phosphate cotransporters NaPi2b and PIT1 regulate that. This is a vitamin D dependent process. At high phosphate concentrations, probably the vitamin D receptor in these don't play a very big role, but under low dietary phosphate conditions or in fasting, the vitamin D receptor can play a bigger role in transporting phosphate into the circulation via this transcellular route. Now, one of the most important ways that phosphate gets into the body is here, and this is through the paracellular route, as we see here. And it's been made apparent within the last number of years that a major regulator of this is the sodium hydroxy exchanger 3, NH3. So as the pH of the enterocyte gets regulated and changed, it makes phosphate absorption through the transcellular route more or less possible, such that this can be manipulated. And there's a new drug that's on the market now, but coming to the market to us for those of us interested in phosphate biology, and that's tenapanor. So tenapanor is an inhibitor of this NHE3 sodium hydroxy transporter. And so it impairs phosphate reabsorption. It actually is already approved for irritable bowel syndrome, IBS-C, that's associated with constipation, and it's under review for approval in renal diseases. There have been several studies that have been done in renal diseases, and it seems that it can lower blood phosphate by approximately 1 to 2 milligrams per deciliter. So a pretty significant lowering of blood phosphate with this drug tenapanor. So this is a relatively newly appreciated regulator of phosphate absorption from the gut. It reveals to us how important this the sodium phosphate cotransporter is. And it also introduces us to the idea that there will be a way to regulate this soon. All right, so next, the bone. Okay, so remember, under normal homeostatic conditions, bone phosphate is roughly matched. That which is formed is matched by resorption. So how is it formed? So the osteoblast takes in phosphate, again through these PIT1 and PIT2, which are sodium phosphate cotransporters, and it generates these little circles here that are called matrix vesicles. So matrix vesicles are little vesicles that bud off from the osteoblast. They're full of hydroxyapatite. They coalesce around the collagen, and they form, again, the hard stuff that makes up bone. So this is matched then, of course, by bone resorption, which is shown here. This takes place through the osteoclast rank-rank ligand pathway, which most of us are quite familiar with. What's interesting about this and should be remembered about this is that for every calcium that's released when bone is resorbed, that phosphate is released too, in about a 5-to-3 ratio. So remember I said that phosphate is absorbed in the gut, it's rapidly absorbed, it's rapidly cleared, there is obligate excretion of phosphate into the urine. So the bone does serve as a reservoir for phosphate, and it serves as a reservoir of phosphate that serves to maintain blood phosphate concentrations during periods of fasting, which we don't often appreciate. This can be revealed, though, when you use very potent anti-resorptive agents such as denosumab, which can bring about hyperphosphatemia, and in patients who have taken high doses of bisphosphonates, such as cancer patients with metastatic bone disease. This can be a problem, and it can be a chronic problem. So over inhibition of resorption, which will then inhibit phosphate release from the bone, which is important during fasting periods, can become apparent with over suppression of bone resorption. Okay, so that's the bone. Now let's move to the most important area of phosphate homeostasis, and that's the kidney. So again, this is a cartoon from Professor Peacock's publication. It's simple but clear and very illustrative. So we see here, this is the glomerulus over on the left end, and it goes out to the urine. And you can see the vast majority of phosphate reabsorption and regulation of reabsorption takes place in the proximal tubule. So phosphate from the urine in the proximal tubule, almost exclusively through transcellular processes, through NAPI2A and 2C primarily. It goes into the cell, and then phosphate on the other side crosses the cell into the extracellular fluid through this xenotropic and polytropic retrovirus receptor, a truly adept name for this sort of phosphate transporter. Anyway, if you see this, you now know what people are talking about. Anyway, the two main regulators of phosphate transport in the kidney are shown here. And this is the PTH receptor and the FGF receptor, where PTH and FGF23 regulate phosphate reabsorption. So this is really where the money is in terms of regulating phosphate homeostasis. So before I go into FGF23 and PTH, though, then I did want to talk just briefly about the sort of differential diagnosis and the causes of hyperphosphatemia. So there are three major categories. One is internal redistribution, and by this, the causes are things like tumoral lysis syndrome, rhabdomyolysis, and cellular shifts, the sort of cellular shifts that can take place when there's diabetic ketoacidosis and treatment of diabetic ketoacidosis and other processes like this. So these are usually profound changes that occur in patients that have very dramatic underlying diseases. It's usually not a mystery as to what the cause is, and the treatment of these involve the treatment of the underlying disease. There can also be increased intestinal absorption of phosphate. This doesn't really happen very often, although it can occur with large exogenous loads of phosphate. So for example, Fleet's phosphosoda has a lot of phosphate, and it was used for bowel preps for colonoscopy and that sort of thing. Rarely, though, does this become an issue except if the patients have some underlying renal impairment. So if you have normal kidney function, this really is hardly ever a problem. But if there is impaired renal function and there's a large enough intestinal load, hyperphosphatemia can ensue. Okay, so again, where the money at is the kidney. So far and away, the biggest cause of hyperphosphatemia is renal failure. This is a huge area that is under study. It's a huge discussion. We won't go into it too much, although we'll touch upon important aspects of this. Then after that, there's a lot of other things that can cause decreased urine excretion. It can be seen in growth hormone excess. It can be seen with some of the new FGF receptor inhibitors, two of which are shown here. And there's really quite a long list of things that can cause it. And this, rather than go through those, I left for you here a recent good review of this topic for those of you who want to be more attuned with the long differential there exists for hyperphosphatemia. What I do want to focus on mostly, though, which is most apropos for this group, the echo rare bone, though, is PTH deficiency and FGF23 deficiency. Keep in mind, though, there is such the entity as PTH resistance as well, so pseudo-hypoparathyroidism. Again, we won't go into that too much, but we'll focus mostly on PTH deficiency and FGF23 deficiency. So before getting into those, and keeping in mind that this is really a mixed group, there's a lot of endocrinologists, but there's also geneticists, there's orthopedic surgeons, there is now and again the lone nephrologist as well. But I did want to talk a bit about PTH and FGF23 and how they regulate not only phosphate, but their larger role in mineral homeostasis. So PTH, parathyroid hormone made by the parathyroid gland, and in this case acts at the proximal tubule cells through the PTH receptor. And it regulates quite robustly the sodium phosphate cotransporters where it inhibits those, and it increases 1-alpha hydroxylase. The result of these two properties, these two actions of PTH, is that it lowers serum phosphate and increases serum 125D, which has the effect of increasing calcium. It also increases bone resorption, which can also lead to an increase in calcium. So this is the net effect of the action of PTH. This stands in contradistinction to FGF. Before I go to that. So then when you have an absence of PTH, hypoparathyroidism, this is what we see. We see increased serum phosphate, hyperphosphatemia. But here, the 125 is lower, which means the blood calcium is relatively lower. Bone resorption goes down, so again, blood calcium is relatively lower. So the net effect in this case is an increase in blood phosphate, hyperphosphatemia. So FGF23. So FGF23 acts at the proximal renal tubule cells through the FGFR1 and the co-receptor Klotho. And deficiency of any of these, FGFR1, Klotho, or FGF23, can lead to low FGF23 states. So FGF23, like PTH, lowers blood phosphate. But unlike PTH, it lowers 125D, so it has the effect of relatively lowering blood calcium. So, though, in FGF23 deficiency, you see an increase in blood phosphate and an increase in 125D with an increase in calcium. The result is that there's an increase in the calcium phosphate product, and this is the problem. And this is a big problem in this disorder, as we'll see later. Okay, so before I get into these two diseases, I did want to return to, just for one slide, to talk about renal failure, which I'll do here. So this panel on the left shows the complex relationship between the regulators of blood calcium and phosphate that occurs in patients with renal failure. It's really quite complex, but I'll try and go through it relatively quickly. This is the sort of complex interaction that occurs in hormonal regulation that endocrinologists love and that it drives other people crazy. Anyway, so as the kidneys begin to fail, as the GFR starts to go down, the first thing that's observed is an increase in FGF23. Now, there's debate as to what this is all about. Is it the case that the blood phosphate is actually starting to rise a little bit, but it's kept normal by an increase in FGF23? Or is it the case that damage to the kidney itself somehow results in an increase in FGF23? It's not entirely clear, and probably both processes are involved. Either way, then the next thing that occurs is as the kidneys begin to fail, and as FGF23 rises, 125D begins to go down. Now, for years, we thought it was the case that 125 went down because the cells that make 125 were dying off. This is not the case. If you were to block FGF23 here, the 125 would go way up. So it is the rise in FGF23 that's decreasing the 125 is the cause of that. And this probably reflects some mechanism of the body to protect itself from hyperphosphatemia, to protect itself from ectopic calcification. Okay, the next thing we see is a rise in parathyroid hormone. So as 125D goes down and the body works to maintain eukalcemia, PTH goes up. And it isn't until after all these processes are in place, when the GFR reaches stage 3-4, the GFR around 30, that you begin to see the phosphate go up. So phosphate begins to rise here. So then what happens with patients with renal failure? Their kidneys are failing. How can we control the hyperphosphatemia of these patients? So there's a lot here. So this is a cartoon that's taken from this recent review here, which is very good. And so the steps that are taken to treat the hyperphosphatemia of renal failure are many, and none of them are very good. So of course, dialysis is the mainstay when patients actually reach end-stage renal disease. Anyway, also then, low phosphate diet. These are often difficult to stick to. Patients don't do so well with that. Phosphate binders. And there's about a dozen different phosphate binders, all with different degrees of efficacy. And really, globally speaking, there's an equivocal benefit from phosphate binders. Nonetheless, they're used quite prominently. Then there's another of other processes that are shown here. So here is tenapanor, which we talked about, and that affects the passive transport of phosphate. There are other drugs that are on their way. This EEOS 789 has not entered clinical trials yet, but is a pan sodium phosphate cotransporter inhibitor. And nicotinamide is a cotransporter inhibitor as well. And I would say that nicotinamide is really not very effective either, as I pointed out here. A relatively new phosphate binder is ferric citrate. It has been shown to decrease phosphate and to decrease FGF23, as well as increase mobility. So then in renal failure now, there are a few renal targets. And one important aspect, and this is shown by this very nice paper by my colleague Pablo Florenzano that was recently published in JASN, is, for example, that in patients with cystinosis who have a Fanconi syndrome, so they have a tubular disease, not a glomerular disease, and the first thing to go, or what is maintained in them, is their ability to lose phosphate, to continue to lose phosphate in the urine. So hyperphosphatemia is a very late finding in them, and they have a very different renal disease and a very different response than that is shown on the left here. So not all CKD-MBD is alike. I also wanted to point out a new therapeutic agent that's maybe on the way, and these are sodium phosphate NaPi2A inhibitors. And this is a recent paper shown here in the American Society of Nephrology. This is a preclinical study that suggests that inhibiting sodium phosphate cotransporters may be effective in patients with renal disease, may be effective in other diseases as well. Okay, now back to really what's the star of the show as far as echo here goes, and that is PTH and FGF23 deficiency. So these shift or fit into two categories. So PTH deficiency is hypoparathyroidism. And again, as we talked about, there's an increase in phosphate with a lowering of the blood calcium. Generally speaking, the calcium phosphate product is normal. However, sometimes, and especially with treatment, the calcium phosphate product can get high, and this can be a concern and something that needs to be thought about and considered. Causes of hypoparathyroidism are many. Again, there's some excellent review articles here that can give you the details about the long list of the differential diagnosis. But far and away, the most common cause of hypoparathyroidism is surgery. So post-surgical hypoparathyroidism. One thing I did want to talk about a little bit here, and that is, do we treat the hyperphosphatemia of hypoparathyroidism? And the answer is, well, it depends. And I have shown down here in the corner this article, which is an article from 2012, which was really an amazing article. This was a patient, this is from Gado Fayun's group. It was a patient who had post-surgical hypoparathyroidism who was lost to follow-up essentially for 22 years. And she showed up with a blood calcium of 3.7 milligrams per deciliter and a blood phosphate of 17.6 milligrams per deciliter with intact renal function. Her calcium phosphate product was 65, so not terribly high for a blood calcium of 17.6. And interestingly, they started to treat her hypocalcemia with conventional therapy with calcitriol and calcium, and her calcium phosphate product went up. They started her on treatment with PTH, and her blood phosphate plummeted after that. So this is to point out that certain treatments of hypoparathyroidism can make the hyperphosphatemia worse. It can make the calcium phosphate product worse. And if need be, this is very well regulated with PTH. I'll look forward to some discussion later. We generally, in our cohort here at the NIH, rarely think we need to treat patients with phosphate binders. Sometimes we treat them with PTH, but typically the hyperphosphatemia PTH deficiency doesn't need treatment very often. Now that stands in contradistinction to tumoral calcinosis, which is the disorder of FGF23 deficiency. Again, high phosphorus, high calcium, high phosphate product. The causes of that can be genetic, as I said before, FGF23, clotho, and GallanT3, which I'll talk about in a minute. Also this case of autoimmune disease, which was published recently by Rachel Gaffney and Mary Scott Ramnitz in our group. And so let me move into a little bit about FGF23 here. So here is FGF23, signal peptide N-terminus, C-terminus. A key and very important feature about FGF23 is shown here. And this is this sequence here, which is a furin cleavage site. So furin can break down FGF23 into inactive N-terminal and C-terminal clips. And what prevents that from happening is glycosylation by this enzyme GallanT3. And so deficiency of GallanT3 is the most common cause of tumoral calcinosis. And without GallanT3, FGF23 is broken down into N-terminal and C-terminal clips. So with this, though, we have to have a little brief discussion about FGF23 assays. So the commercial assays for FGF23 are ELISA assays. And the way they work are shown here. So the most commonly available and used assay is this one called the C-terminal assay. This is the one that's performed by Quest and Mayo and other laboratories like that. And what you can see is that the two antibodies that are used to generate the signal from this assay, both of these antibodies target the C-terminal domain of this assay. So while it's a C-terminal assay because the antibodies attached on the C-terminal, it also detects intact FGF23. But the problem is it doesn't distinguish between intact FGF23 and the C-terminal FGF23, which becomes important in a disease like familial tumoral calcinosis. On the other hand, the intact assay, which is shown here, only detects intact FGF23. The Mayo Clinic has just recently started offering this assay. I think it's an important thing to know, and it's important to have this in our armamentarium. Where this becomes really important in the diagnosis of tumoral calcinosis is shown here. And so this is our group of patients here at the NIH with tumoral calcinosis. And as you can see, or can't, you can, is that the intact FGF23 levels in these patients are very low, undetectable. You know, it was interesting when this disease was first discovered, and the only assay available at the time was a C-terminal assay, and they had predicted that these patients should have very low FGF23 levels. Well, on the FGF23 assay, in fact, they saw just the opposite. The C-terminal FGF23 levels are quite high. Anyway, as the intact assay became available, we now see that, as predicted, the intact levels in these patients are quite low. And this is really a good example of the utility of using both of these assays in patients. In fact, it's critical in the diagnosis of tumoral calcinosis. Now here's a little bit more about tumoral calcinosis. So on the left side are photographs and x-rays of patients with tumoral calcinosis. So it's called tumoral calcinosis because these big collections of calcific material look like tumors. They feel like tumors. So tumoral calcinosis. They're not really tumors. They're collections of hydroxyapatite. So this is hydroxyapatite that can be in the form of liquid. So sometimes it's an oozing liquid that looks like pus. That's called milk of calcium. Other times it can be a collection of soft tissue. And then sometimes it can be quite compact and almost like a cheese-like substance. Either way, analysis of this material reveals that it's collagen-free hydroxyapatite. The biochemical profile is, as was shown before, the intact in FGF23. The phosphate is frankly high. The blood calcium is on the high end or frankly high, giving a high calcium phosphate product. The 125D level is generally in the normal range, but in hyperphosphatemia, 125D should be low. So this is an inappropriately normal 125D. And the PTHs are generally suppressed due to the relatively high calcium. It's a fascinating disease with a broad spectrum of findings, some of which are shown here. So this is a histological specimen of the calcification. Again, it's hydroxyapatite. You can also see within areas of the calcific material bone formation. So this is lamellar bone that's formed within a calcific area. And also an interesting feature of these lesions is these macrophages that can be seen. And so these are foamy macrophages that are very, very pro-inflammatory. Right here is an electron microscope image of a macrophage that's ingested these hydroxyapatite crystals, which is contributing to the inflammation. And some of these patients can really have dramatic inflammation. CRP is greater than 200. So inflammation can definitely be a part of the disease with some of these patients. It often occurs during a flare when a lesion is forming. Shown here, though, in this other panel here with this X-ray of the tibia is a form of diaphysitis that only occurs in the juvenile period. It can often be the presenting symptom. And this gave rise to the syndrome, what was called hyperphosphatemic hyperostosis syndrome, HHS, which is just another name for tumoral calcinosis. Not all patients get this. Sometimes, as I said, it's the presenting symptom. It's often misdiagnosed as osteomyelitis, and in fact, these patients are often put on antibiotics. Only occurs in childhood, usually goes away, sometimes the presenting symptom. What, though, I wanted to point out, and I have a little asterisk over here because I think it's really important, is the fact that there is a distinct dental phenotype in patients with familial tumoral calcinosis. It's usually the first thing to show up. It's the most penetrant part of the phenotype. And if you see patients, or if the dentist sees patients with these distinctive findings, they can actually be the first person, the first clinician to point these patients to the correct diagnosis. Generally speaking, it doesn't have a profound dental phenotype in terms of pathology, but it is the most penetrant feature of the disease. These patients can get peripheral vascular disease. Surprisingly, they don't seem to get a lot of coronary artery vascular disease, but they can get peripheral vascular disease, so this can be an important feature of that. So this is part of the broad spectrum of tumoral calcinosis that can be seen. There's also within families a significant variability. So these are two brothers that we saw here, a 29-year-old and a 15-year-old. The 29-year-old is shown in this panel here, and you can see he just had profound calcification over many, many parts of his body, shown here around the shoulders, around his hip. He had calcifications in the submucosa of the gut. He had subtle calcification of the aorta and the papillary muscles. And his biochemical profile is shown here. He started with hyperostosis when he was 7 years old. His phosphate is shown. His calcium phosphate product is high, but not crazy high. It's only 53, but look at the calcification he has with that. His 125 was high, his PTH was highest, intact FGF23 low, C-terminal FGF23 high, and a very elevated CRP. In fact, this patient at one time had a CRP that was over 200, so really profound inflammation. So this is his 19-year-old brother. And look at his biochemistry. So his phosphorus is higher than his brother. His calcium phosphate product is higher. His C-terminal FGF23 is higher. But he has no calcinosis whatsoever. His only feature was shown here, which is this subtle Renal phenotype that he had that I talked about. So why is it that this 29-year-old who started when he was a child, this 19-year-old who only has this subtle dental calcification, is it the fact that this patient does have a fair amount of residual intact FGF23 and that's why that happens? I'm not sure. It remains quite a mystery. Anyway, I wanted to move into now the treatment of tumoral calcinosis, and then we'll end there and open up for questions and discussions. So, low phosphorus diet goes without saying, not great, doesn't work so great. Phosphate binders, in these patients, because they have intact renal function, they can tolerate aluminum hydroxide, not get aluminum toxicity. So you can actually use two different phosphate binders. Again, they're not the greatest. Efforts to increase renal phosphate excretion. We tend to use acetazolamide and probenecid a lot. And for those patients who have very dramatic inflammation, we will also use potent anti-inflammatory drugs like IL-1 blockers like anakinra and canakinumab. I should say that topical thiosulfate has been advocated, and some people have shown benefit with this. There's publications to that end. We've tried it and not seen tremendous benefit from it. There is the reported case of daily peritoneal dialysis, which is a dramatic step, but sometimes these patients have dramatic disease and can be used. Surgery when you have to. I'm excited to say that I think there are some things in the future that can be potentially beneficial for these patients. Tenapanor that we talked about, FGF23 replacement is an option. And I think the sodium phosphate cotransporters represent a real potential treatment for these patients. So that will be seen in the future too, we hope. I'm going to end with that. And as I was putting this together, I realized I don't have any pictures of my current group. And then I realized we don't have any pictures of the current group because we never get together as a group anymore. Hopefully that'll end here shortly. Anyway, this is the group that I work with at the NIH, and I will stop there and open it up to any questions or discussion.